So if you, and these are kind of unusual gifts, but they're actually thermos, but they look like bullets. They're kind of cool. So if you guys know the answers to hard questions, whoever answers them gets them. These are actually in the back of our marketing department, but they're still kind of cool, right? And for if you answer a kind of hard question, you get a mint to compliment your. So, the knee, and I will be completely transparent up front. I will probably talk a little bit faster this one, because my wife's birthday gift is I'm taking her to the Ed Sheeran concert in Tulsa tonight. So, if you guys don't care, I'm going to talk a little fast, we all get out of here and not get in trouble. Okay. So, anybody opposed to that? Okay, so I think we already talked about this last time. This is me, you can read it. Today's discussion, evaluation of the knee. You know, you guys are far enough in this now that you know how to take a history. How did you do it? What makes it feel better? What makes it feel worse? Have you seen someone else? And that's, if you're in orthopedics, that's the biggest thing is have you seen someone else? Because sometimes I'll go through my whole spiel and come to find out they've already had injections and MRIs and all this other stuff, where if I would have just said, hey, have you already seen somebody else? They'll go, oh yeah, this guy did that for me already. So always find out, once again, how they do it, what makes it feel better, what makes it feel worse, what are you taking for it, have you done any treatment, therapy, shots, anything like that. And then at the end of this, we'll go through some pearls and questions and stuff like that. Anatomy of the knee. The knee is, compared to the shoulder, the knee is a cakewalk. You've got 3 bones, 4 ligaments, 2 meniscus, and a whole bunch of muscles and tendons that surround it. You know, in medicine there's an old saying that common things happen commonly. So you'll hear people, just like we talked about last time. Remember people over 40 with, I can't sleep on my shoulder, it's a... There you go, right? So you already remember that part. So this is kind of the same thing. And you'll see this, and you don't really get it until after you've been out a little bit, but you'll start to see these things coming over and over again. This other one was already on there, but I just left it on. Okay, so evaluation of the knee. Patient's positioning, obviously laying on their back. So if they're on a table, you want their affected extremity closest to you, kind of common sense stuff. Minimal movement on the part of the patient. This is what we talked about last time. Don't have them stand up and sitting down a bunch. This says perform everything bilaterally. Usually if there's something that I'm leery of, I'll go ahead and check the other side. So if you're checking somebody for their ACL, some people are actually just ligamentously lax. So their knees are both loose anyway, so you can do an anterior draw arm and go, ha, you have an ACL tear, and you'll go over and you'll do the other one, you'll go, crap, you're ligamentously lax, I have to go back to the drawing board. So always, if you're skeptical on something, even on x-rays, like growth plates and things like that, if something just doesn't look funny, or looks funny to you, go ahead and x-ray the other side, because then you can say, oh, well, the other side looks just the same. It may not be actually something wrong, it may just be how they're built. Get in the habit of performing the same routine. This is what we talked about last time. Find your rut and stay in it. Get your exams how you want to go, because when you do that, you don't forget stuff. And when people start skipping around and trying to change up stuff, you'll start forgetting exams, and then you'll forget or miss something. Hops. This was on here from the presenter, whoever was gracious enough to loan me their stuff. History. Once again, we just went through that. Observation. Is it deformed? If they come in and their wrist looks like this, or their knee is to the side at a 90-degree angle, there's a deformity there. Open wounds and abrasions obviously need a lot more attention in a quicker fashion. The 3 E's, the edema, effusion, and ecchymosis. Do you guys know the difference in all of those? Effusion, edema, ecchymosis, okay? Loss of contour. Sometimes whenever people come in with a badly sprained ankle or sprained knee, sometimes it's so swollen you can't even see their kneecap anymore. So a loss of your anatomic landmarks is a pretty good signal of some things. Obviously color changes. If somebody comes in and their leg is blue, you would probably think they're not getting blood flow, right? And if it's cold. All right, so palpation, effusion versus edema. Usually a edema is more superficial. You can kind of play with it like a water balloon. It almost has this fluid appearance, where in effusion, there's not a lot of movement of that. They just have a very swollen knee. Crepitus, everybody knows, is the grinding, I call it Rice Krispies or Velcro feeling in your knee during range of motion. Mechanical symptoms are popping, locking, clicking, and catching. Those are almost, anytime people come in saying I'm having popping, locking, clicking, and catching on a knee, you're already thinking meniscal tear. Those are the most common things that people gripe about. Pain over the anatomic landmarks, once again. All right, going too fast, too slow, everybody good? All right, so special test, patellar apprehension. Now you guys have had phys die on the knee, right? Okay, so you remember patellar apprehension. Your kneecap always goes which direction whenever it dislocates? Laterally, okay? So it immediately, this is my 16th year and I've seen it happen twice, and one was because somebody actually got hit with a baseball bat that pushed their kneecap that way. So it has to be usually something pretty traumatic, just the way that the knee is built itself. So patellar apprehension literally means if you take their knee in a straight position and you start shoving it laterally, they'll start going just like their apprehension on their shoulder. Ooh, hey, that's not good, that's going out. Meniscal injuries, Apley's, McMurray's. I don't do the deep squat duck walk because if they have a positive McMurray's and a positive Apley's, I'm not going to make them get down and do a duck walk. You can actually mimic that on the operating table. Don't do it that way. But if they're laying down on the bed, you can do a duck walk by simply just hyperflexing their knee for them. So if they're laying down, I know I picked on you last time, so I won't this time, but if you can just literally just take them and hyperflex their knee, because meniscus tears do not like to be put in a hyperflex position. Ligamentous laxity, everybody knows the difference in valgus and varus, right? Okay, Lockman's anterior drawer, posterior drawer, a pivot shift. Do you guys know about a pivot shift? I don't know if they taught you that in phys diet. So, whenever we have a sedated patient getting ready to have surgery, most people will not let you do this on them awake in the clinic room. It is not very comfortable. Basically, a pivot shift is so if I have a patient laying here, it's their right knee I'm evaluating. A pivot shift is if you have them relax and you get them so their ankle's down here, my hand's on the lateral aspect of their knee, you go from a straight position and you put a valgus stress on it, and as you go up, and you're putting a pretty good one on it, a pivot shift is that their ACL's torn. Once you get to a certain degree, it'll go boop, up like that, but it hurts really, really bad. So we usually only do that in the operating room if there's not a for sure diagnosis of an ACL tear, like if the MRI may be wrong. We get in there and we look at it, MRI says it's torn, well we're looking at it through the scope and it doesn't look torn, we'll pivot shift them, because no matter what happens, nobody gets fooled with a pivot shift. If it's negative, they are not lax enough to have their ACL repaired. Does that make sense, kind of? Okay. All right, so my sequence, once again, I kind of got into this last time. Palpate for effusion versus edema, patellar apprehension, document passive and active range of motion. Pain with terminal range, once again, is usually a meniscus tear. Meniscus do not like to be hyperflexed. Crepitus, you'll feel it behind their kneecap. You can test it on yourself right now. I've got it. I don't know if you guys are old enough to have it yet, but if you just put your hand on your kneecap and straighten and bend it, it feels like Rice Krispies under there. Meniscal testing, once again, ligament testing and other special tests like the pivot shift. All right, so bursitis. Inflammation of small fluid-filled sacs that presents at the point of high friction. Most common are prepatellar and pes anserine. So this one's kind of a common one. We'll have people who lay carpet, lay tile, do roofs, anything that you're bending down and kneeling down a lot. They'll come in and they'll go, yeah, I was fine yesterday, and this morning I woke up and I've had this little water balloon on the front of my knee. So the most common by far is the prepatellar bursa. And I know this is kind of hard to see, but you actually, all these little black dots are bursas. So you've got your suprapatellar, your patellar, prepatellar, this pes anserine down here in the posterior one, which I've never seen really. You can, that's would be more like a Baker's cyst type thing. Once again, chief complaint is over the swelling. Most bursitis, unless infected, are not painful. They've just got swelling on the front of their knee. They usually will not have intra-articular pain with bursitis unless it's one of the other ones. But like I said, the most common are prepatellar bursitis and the pes anserine bursitis. All right, so exam findings. So as you can see on this, so would you call that an effusion or edema? Or bursitis. Right, so see that's where it kind of gets hard, right? Because it's fluid, you can bounce it back and forth and all that. So that would be an extra-articular swelling. So, and then where the pes anserine is down here, you can see this right here. So, for one of these lovely thermoses, does anybody know what pes anserine means? Like the translation. I like it. She's like showing me hand puppets. Yes, that's good, but I need to know the name.
That's like fluid joined together.
Okay.
Goose.
Who said it? I heard it.
I googled it though.
I mean,
Goose
whoever's
foot.
fastest, right? So what is it?
Goose foot.
Goose foot. And you know why it's called a goose foot?
Because the tendons of the three muscles that insert onto the anterior.
So what tendons are they? We hand that down there. What tendons are they?
They are the sartorius. No wait, those are the muscles.
It's right here on this picture.
Oh, that's the picture I was looking at.
Little hint. Sartorius gracilis and semitendinosus. So it's called the pes anserine. And the hard part is when you ask most people off the street, where's your knee? They'll go, right there. And so the problem is, and I'll even go back and say, look, my hand is covering your knee right now. Because what they don't get is the pes anserine is right there. And if that thing is swollen and tender, they will still equate that with knee pain. Well, if my knee hurts, why aren't you giving me a shot in my knee? Well, I'm not, because it's below. So I always tell everybody that are next door neighbors, this is your knee, intra-articularly, this is your pes anserine bursa, and this is not part of this. We even have people, and one of the most common things is after people have had a total or a partial knee replacement, they'll come in going, Doc, I think something's wrong with my knee. I think I messed it up. It's really tender right down under, right here on the inside. And so in your brain, you're already going, oh, that's pes anserine bursitis. Go ahead and check out everything just because you don't want to miss anything. But that actually happens quite a lot. Pain with active range of motion, increase with friction over the inflamed bursa. Otherwise, normal exam, their McMurray's, their Apley's, their anterior drawer, posterior drawer, all of that stuff will be completely normal with bursitis. Okay? Any questions so far? Okay, so workup most often in clinical diagnosis, almost always. I don't usually, we won't MRI bursitis. May need an MRI if you're suspecting something else is going along with it. And radiographs will not show unless calcific. Not necessarily true. If you have a pretty inflamed olecranon bursa, you will see a big hump on the x-ray. It's not part of their bone. Treatment, once again, rice, antibiotics for septic bursitis. Now, usually septic bursitis, it's not one of those. It's kind of like when you tear your Achilles tendon. You don't say, hey, I wonder if this is infected. I mean, it is red. They look sick as a dog. If you've ever seen somebody with a real bad flu and you just walk in the room and you're like, oh my God, don't touch me, don't breathe on me. These bursitis are very, very red. They will not bend and straighten their elbow. They will not bend and straighten their knee. They won't even let you touch it. And the reason that that's a big deal because all these bursts are around joints. Well, if you leave that bursitis infected, it can seed the joint. Now you have a septic joint. Now they're going to the hospital. Okay? So treatment, once again, you can do all of those things, the icing, the anti-inflammatories, all of that. Invasive is aspiration of the prepatellar, and this is where this gets kind of tricky. We will aspirate the prepatellar because it's sticking way off the front of their knee like a clip. It's very, very easy to aspirate, not going to hit anything. We actually don't aspirate the pes anserine. You would just inject that straight with 2-in-1 injection, which is in our clinic is a steroid injection mixed with lidocaine. Because usually the pes anserine don't get huge like that, so it's not just like sticking a water balloon. You're just going to inject it instead. The rule of thumb on bursitis is that if we drain it 3 times and it comes back a 4th, we're going to cut it out. Because every time you drain it, you put something outside the world inside their world. If you keep doing that over and over, you're just setting yourself up for you to potentially make it infected. So even under sterile technique and all that. So once again, the rule of thumb is drain it 3 times. If it comes back a 4th and they don't want to live with it, then we will then cut it out. Once again, this is most commonly on olecranon bursitis. I can't remember the last, we've had maybe 2, I think we've cut out 2 prepatellar bursitis this year. And just because, not because they were infected, because they were just bothering these guys whenever they're roofers and carpenters and things like that. So, all right, ligament injuries. Tom Brady, right there, for those who watch football. Injury to one of the main 4 stabilizing ligaments of the knee. So, of course, you have your MCL, ACL, PCL, LCL. They have this grading scale, and you can go by that. And I don't know the last time I actually dictated this is a grade 1 MCL sprain. Usually, you'll dictate that when you send them for an MRI, and the radiologist will call it a grader 1, 2, or 3 sprain. The way that we kind of do it is either something is still attached or it's not. Either it's ligamentously lax or it's not. Is there a palpable endpoint? And that's actually part of my dictation. So medial collateral ligament, classic case, competitive football player struck on the lateral aspect of the knee buckles in at a valgus stress. Believe it or not, this is actually the most common ligament injured. Everybody always hears about the ACLs because those are the high profile. It's devastating, Adrian Peterson and all that, even though he came back in a ridiculous amount of time. I think he did his whole rehab and was playing in like 2.5 months when it takes the rest of us humans like 6 to 8 months to get over that. That dude was a machine. Occurs when valgus force is obviously placed on the knee. Medial sided knee pain, onset of effusion is 1 to 4 hours. This is different than the ACL. When you tear your ACL, it will get huge. Has anybody in here ever torn their ACL? Really? Nobody? Do you guys ever play sports at all? Anybody here? Well, you guys are lucky, but when you tear your ACL, it will balloon up quick. In fact, if you don't get ice on it within about the first 30 minutes, we don't even examine it until the next day because it's already so big, we can't do anything with it. Inability to bear weight initially on the knee. So what will happen is they'll say, man, whenever I put my weight on it, it feels like my knee wants to kind of go in like that. My knee gave way or knee buckled on me. So once again, most commonly injured ligament, but by far not the most glamorous. Medial knee pain is at the origin, which is the most common. So if you divide into thirds, proximal, middle, and distal, proximal is the most common, middle is kind of in the middle, of course, and the least common is distal. Laxity during varus and valgus stressing. This is one of the things, valgus stressing, I apologize. Here's the thing about a knee. When you're doing the exam, so if I have my pretend patient up here and I am doing that valgus stress, if they lock up their leg on you, if they, what we call a quad sit, if they make their leg as tight as they can actually give you a false negative because they can stabilize their knee by hunkering everything down. So whenever you do an MCL exam, I want you to have one hand underneath the one that's pushing medially, and I want you to do it at 0 degrees, and I want you to bend them up at a 30-degree angle and then do it again because they can't flex their leg at 30 degrees, so they can't lock it up and give you a false negative. Once again, whenever I'm doing these exams, it comes down to if I have their knee right here, so to me, it's either going to be tight compared to their contralateral side, it will be loose with an end point, and you'll kind of feel it like if I had a loose rope attached to the wall, and I was pulling it, and even though it was lax, I could still feel an end point. It would still jerk at the end. So if you go out further than the other knee, but it still stops, that would be a grade 2 because it's not completely torn. And if you take it and it just keeps on going, that's a grade 3, even though it really doesn't matter that much because you're still going to get an MRI. Don't admit other tests after the positive valgus because, once again, is it possible to hurt more than one thing during an injury? Well, sure it is. So you don't want to skip over those things. All right, so once again, grading, always compare the contralateral side. Grade 1 basically just means you have sprained it, right? It's a ligament, so it's sprained. Grade 2 means you have probably injured the internal fibers of it, but not a full thickness tear. And grade 3 laxity, there's no resistance. It's just flapping the limb out there. Workup, routine radiographs may find an avulsion from the fracture of the distal side. It'll sometimes pull that off or proximally. That's not very common at all. I can't remember the last time I've seen that. Kind of a board's question here. The answer is an MRI, primary care, all of that stuff. This guy actually wrote an isolated MCL strain doesn't need an MRI. You might as well get the MRI because, once again, it'll also do one of two things. It'll let you know the severity of it. It'll also find out, did you do anything else? Did the patient do anything else while they were injured? And then go from there. As far as treatment, so the way that it works is that your MCL and your LCL, so everything that I'm telling you about your MCL also applies for the LCL, the same treatment except for the surgical part, of course. So what we would do is if you have somebody come in, they said, hey, I got hit from the outside in, I feel like my knee's going to wobble, you give them the old test and everything's positive for it. We put them in a flexion extension brace. You guys have seen those, the ones with the dials on the side, and we lock them into a 30-degree angle because your MCL is on its most tautness, I don't know if that's the right word, I just like saying it, so it's at its most tautness at 0 and 90 degrees. So whenever you come in to the room and you see somebody with an MCL, if they're sitting up, they'll be sitting like this. They don't want to be like this, and they sure don't want to be like this. That's why whenever you're examining them, whenever you put their foot at a 90-degree angle to do the anterior drawer and the McMurrays and all that, they don't want you to do that. So we would put them at 30 degrees so their MCL and their LCL can relax. Once again, they differentiate all this grade 1 to grade 2s. To me, it's either torn or it's not torn. We would still get an MRI, we would still put them in a flexion extension brace, and the crutches, I don't know if you've ever tried to walk around with your knee at a 30-degree angle, it's very, very difficult, so you might as well give them some crutches. Rest, ice, compression, elevation, anti-inflammatories, narcotics, I mean, it's usually not one of those things, but if it's hurting them bad enough, or they have maybe another injury associated with it, we'll go ahead and do that. I'm just not a big fan of putting kids on narcotics. And then referral to me. The vast majority are non-surgical. I can't remember the last time we've actually fixed an MCL. MCLs and PCLs are so rarely fixed that, honestly, I really can't even remember the last time. LCLs, the injury itself is almost never, so we don't fix that many of them just because they don't get injured that often. Multi-ligament injury or MRI evidence of a distal insertional injury may require surgery. So if you tore your ACL, MCL, everybody knows unhappy triad? Yeah, okay. So if you know that and you have that, well, of course, then they're going to have surgery. So if your ACL is torn, MCL is torn, sometimes they'll go ahead and fix that. But once again, that's not a very common case scenario. Physical therapy for range of motion. So what we do is they will be locked in a flexion extension brace at 30 for 3 weeks, and then after that we will give them open for 3 weeks, but they still have the stability of the brace to go varus and valgus. And then modalities, which modalities are things like ultrasound, iontophoresis, E-stim, all of those things. This says 4 to 10 weeks. I tell our folks, we can usually have you back out on the field if everything goes well and they listen to us by about week 8. That's realistic. Same thing with an ankle sprain, week 6 to week 8. The MCL sprain is the only one that if I'm standing on the sideline, that's the only one that I'll just go, you're done. Believe it or not, people play football games on ACLs. LCLs, once again, so uncommon, it's not even really a factor. PCLs are hard to find, number one, and even if they do, sometimes people can continue on them. But the one thing that I will not let somebody stay on the field for is an MCL injury, because then it can start tearing up other stuff. All right, anybody on the MCLs before we move on? Okay, so remember, just the tidbit on that is make sure that you examine them at a 0 and a 30-degree angle, because you'll see the first time you ever examine somebody's knee, like whenever you guys do your test on each other and stuff, just have the person who's the patient just flex their leg as tight as they can and see if you can even try to move them, and you can't. So I always just try to kind of roll their foot off the side of the table and then bend it at about a 30-degree angle, and you'll get a lot more with that. Okay, so the ACL, once again, the high-profile one, just because, you know, everybody gets freaked out about it, and rightfully so. Once again, the average rehab time on this is roughly 6 to 8 months, closer to 6. Provides rotational stability for the knee, as well as prevents excess anterior tibial translation on the femur. There's some case scenarios on here, but it's usually the people who are the basketball players, and they're dribbling down, and then they'll plant, and then they'll shoot, and they'll go, man, it was kind of weird, I just felt the pop. And once again, their knee swells up enormously right away. There's no waiting for it at all. And then they'll, of course, feel unstable because their tibia wants to translate anteriorly. So, for another thermos, how many ACL injuries are non-impact? Which means I didn't get hit by another person, nobody cut my feet out from me, I'm just the soccer player out dribbling the ball by myself and made a cut of the tennis player.
70%.
Oh, bang, right off the bat. That's the sign. So 70% of people who tear their ACLs never got touched by anybody else. I know it's kind of weird, camo and all that, but I'm sorry. So 70% of people, so everybody always thinks it's these hockey players that got rammed in the wall. It's these football players that got hit by somebody that weighs 400 pounds. No, it's the 100-pound soccer girl out there dribbling by herself in the flats, or the receiver that went out on his own post route or something like that. Very, very rarely do people get hit when they tear their ACL. Once again, large effusion onset was in the first 4 hours. No, it's in the first 4 minutes. It happens very, very quickly. Feelings of instability getting away. They usually feel a pop. Usually MCLs, LCLs, and PCLs don't really feel a pop just by history. But ACLs, they'll go, yeah, I felt a pop. And then loss of range of motion, either inflection, extension, or both. So this right here is a partial tear. So here's your ACL. This is a avulsion, and avulsion is whenever it just pulls straight off of the bone, and then a complete tear, of course. And sometimes if it's in an adolescent, it can actually pull the tibial spine off. So you know when your ACL and your PCL come down attached, sometimes it leave them pull a fleck of bone up, and we just fixed one of those the other day. And what you do is you just put a screw down through that fracture fragment, and it fixes the ACL at the same time. Yeah.
Is the knee going to swell with a partial tear as well?
Well, Dr. McNeil, correct me if I'm wrong, but there's actually an artery that goes down through the middle of the ACL, right? And that's why it swells so much, because it's pumping blood in the joint real quick.
Right, and that's why ACL tears or ligament tears are usually bloody taps versus a meniscal tear is usually not.
Does that make sense? Okay. All right, so now this is some of the exams. So allotment, and the hardest part about teaching physical exam, and after the 2 students that I've had so far from last year's class were both girls. And no offense, but girls usually have smaller hands, right? So whenever you get a 350-pound football lineman, you go, hang on real fast, Bubba, I'm just going to put my, and I'm going to, they can't get their arms around, right? Because, I've got big hands, so I can do it. Even sometimes I have to use my forearm, because you're going to have some huge people if you go into sports medicine. So allotment is basically just what he's doing, although that looks like that may, I don't know what she's laying on, but basically if they're laying on the table, you just let their leg relax. So if you have somebody's feet towards the sky and you tell them to relax, they'll go over like that. And basically you put I use my left hand up top, so you'll put your left hand up above, and if this is their kneecap, right like this, bottom hand below. And the one thing you don't want to do is tell people what you're doing. Because if you say, hey, I know you're in pain, I'm going to yank on your knee real fast, they'll go, no, you're not, and then they'll flex it out again. So once again, what I'll do is I'll say something stupid. Tell me how to spell your last name again. And as soon as they start talking, pull it, right? Or, hey, is it raining outside still? If I'm in a room of ours that doesn't have a window. You've got to distract them. It works on giving shots too. But if they'll distract them, their brain doesn't guard, and you can actually get a better exam. Because if you say, hey, I'm going to pull on your knee, you're not going to pull on their knee. So once again, proximal hand grasps the distal femur, the other one grabs, puts your thumb right on their tibial tuberosity, and it's a jerk. It's not a water skiing, and that's the other thing that students make the mistake of. They'll get them and they'll go, and you know, it's almost like they're pulling back a bow and arrow. The longer you give them to tighten up their muscles, the more they're going to. So it's a jerk, it's a like that, and that's it, and you're done. And once again, if it comes out further than the other one does, then you're already suspicious of an ACL. Lachman is the most sensitive and specific test for ACL. Once again, the problem with doing this one, the anterior drawer, is what can they tighten up that would make their knee not come out? What muscles bring your knee, foot towards your butt? Your hamstrings. Hamstrings are a big, powerful muscle, right? So if you're sitting there and you're trying to pull forward and they tighten up their hamstrings, it'll suck that tibia right back down in there and you will get a false negative. But still do it anyway. The Lachman's good if you can get your hands around their legs. Anterior drawer, flex knee to 90 degrees, foot flat on the exam table, and then as you can see, they have both of their thumbs on the tibial tuberosity, and what I do is I'll tell them to relax, and whenever they relax, their leg will actually start to fall off of the table towards you, and as soon as you feel that give way, once again, you're not water skiing, it's a quick jerk, and I'll even do anterior and posterior at the same time. Just do jerk front, jerk back, and what you'll feel is, you'll feel it stop. There's an abrupt stop if they did not tear their ACL. Once again, it's almost like the slack's getting taken out of the rope and it'll just stop. This basically just describes everything that I just said. So grading of the Lachman in the anterior drawer, once again, this is good for probably boards and test questions and things like that, but to me, it's either torn or it's not torn. And either way, as an orthopedist, we're either already going to have an MRI that proves it, or we're going to be getting an MRI that proves it. So, and it's hard to tell, honestly. You're lucky if you can get them relaxed enough to even get a positive or a negative. So for you to get out your little measuring, your ruler and go, well, I think it was about 7.5 millimeters, nobody cares at the end of the day. ACL sprain workup radiographs often show no acute injury. You may see a tibial spine avulsion once again. So if you have somebody that's skeletally immature, you've got to look for that thing because you'll only see it on the lateral a lot of the times. You can see it on the AP sometimes if it hasn't, but sometimes it's more like a car hood, like that. So then when you look at it from the lateral, that's a lot easier to see than this, right? Rule out tibial plateau fracture, especially if there was trauma. I got hit by a bus, I fell out of a car, or something like that. MRI, once again, gold standard. And here's where you see it. So if you look at an MRI, so just to orient you, femur, tibia, patella, quad tendon, patellar tendon, your ACL is this little black line right there. And what's crazy is, so as you see, the ACL is very taut. It is a straight diagonal line. Your PCL actually kind of makes a little loop right there. Everybody see that little arch right there? So obviously whenever it is torn, you see how this one is kind of sagging. It goes up and then goes up like that. So that means it's a mid-substance. Most of them tear mid-substance. And then this one, you can't even really see it anymore. It just kind of flops over. If people, sometimes they'll even come in if they've waited for a while, and their ACL will actually be trying to scar down to their PCL. So when they get the MRI, it just kind of looks like a bird's nest in there. All right, aspiration of hemarthrosis is on clinical judgment. The way that we do that is the only time that we ever drain a knee is if we think you have an infection, number one, or if you're so uncomfortable and your knee is so swollen that we cannot get your knee to a 90-degree angle. So if you come in the clinic once again and you cannot comfortably sit like this with your knee hanging off, if they ask me to, I will. Once again, I don't offer that a lot because I don't want to stick a bunch of needles in people's knee. However, if they're so miserable and they're writhing around in pain and they can't let their leg hang down like this, I'll go ahead and aspirate it, of course. And the hard part is sometimes it will come back before they even get home. So it's not something we do commonly, once again, unless we're trying to use that for diagnostic purposes. Weight bearing is tolerated on crutches, knee immobilizer, or brace during ambulation. Early range of motion, physical therapy for range of motion or severe effusion, because therapy is very, very valuable, as we talked about with the shoulder. go ahead and refer them on to an orthopedic surgeon. Some primary care doctors, if they're suspicious of that, they'll go ahead and order the MRI so we have it when they get there. It does speed up the process, so we always appreciate it. But if not, just get them immobilized, get some ice on it a lot, anti-inflammatories, and then send them to us and we'll take care of the rest. ACL reconstruction is no longer just for competitive athletes. We did one on a 50-year-old the other day. So as long as there's not any associated osteoarthritic changes and things like that, as long as they're competitive and athletic and still wanting to perform everyday activities or have just a wild amount of instability, we will still fix them. It used to be nobody over 40 and that kind of went out the window. Counsel patients extensively if they choose a non-operative agreement. We actually had an athletic trainer of ours that did not have one for 13 years, and this guy would go snow skiing, water skiing, play golf every day. I mean, you name it, this guy was Mr. Extreme Sports. And after about 13 years, it started to get the best of him, and he had his fixed, I think, when he was 48 after all that time. So once again, it's not just a young kid's injury anymore. All right, ACL tears generally considered to be surgical injuries. Argument exists on the capacity of the ACL to heal due to lack of clot formation. You guys can read all this. Did I do something? Mine went off. Did yours go off?
Keep talking.
Okay. Well, yeah. So the ACL won't heal. Rotator cuff tears, just like I told you guys last year, last week, you can leave them there their whole life and it will not heal. ACLs can try to scar in, but as far as having the actual stability of your God-given ACL, it's probably not going to happen. Okay? So,
I just want to say for this and then I'll.
did I do that? Or
No, it
did I-
does not. It's every day.
Oh, nice. Okay. But you guys can still see it on your computers, right? So can I still scroll down with this? Okay.
Yeah.
All right. Oh, so here's another one. What % of the time do you tear your meniscus when you tear your ACL?
15.
Close with 50.
60.
60. Who said 60 first? She did? Okay. Well, there you go. So that's the reason why you check everything, because 60% of the time, because people always say, well, why are you putting me in a brace? Why are you don't want my braces? Are you kidding me?
I was like, we both said it, so I was like.
Oh, well, here. Well, you guys, here, we'll do, I don't think I have any other big questions, so there, you both get one at the same time. And I'll give everybody else a chance. So that's the biggest deal, is always check everything, right? The MRI is gonna show you that, but 60% of the time, so when people say, why are you putting me in a brace? It's not that bad. Your older people usually don't like wearing braces. And that's the reason why, because if you imagine your bone, if you're looking at, this is my femur, this is my tibia, and it's supposed to work like this when you bend and straighten your knee. When your ACL's torn, it does like this. So you can imagine that shearing force, if left alone over time, will probably end up tearing a meniscus. So you can actually not have a meniscal tear at the time of your injury and get one because you didn't immobilize it properly. So that's why when they come into your, thank you for putting that back up, by the way, come into your office, you want to get them stabilized for the most part. Now, if they say, look, I did this 6 years ago, don't put them in a brace unless they're just having that much instability. Reasons to reconstruct surgically, once again, if they're 55 or 60 and all they do is garden and golf and they can play golf without having an ACL, it's not a fun surgery to go through. And most people who are, once again, in their 40s and 50s, with myself being one of them, they don't want to be down for 6 months. They can't afford to miss a month's worth of work. And once again, maintain articular, cartilage, and meniscal viability. Because remember, if it'll tear a meniscus with that shearing force, it can also start to mess with your articular cartilage. All right, anybody on ACLs? Any questions, concerns, anything like that? Does anybody else know why girls tear their ACLs more than boys? I don't have any more silver thermoses. What? Yes, your Q angle, right? The way it goes out. Anybody else? It's the way you're born. So your femoral or your intercondylar or not, so your medial femoral condyle, lateral femoral condyle, females are more narrow. So it gives your PCL and your ACL less room to live. Second thing, what do girls have that guys don't? And that's why I went to orthopedics, so I have to talk about OBGYN stuff. But if you remember, at certain times of certain days, your hormones are different, right? So it lets things become stretchier, right? So you can actually tear ligaments easier during that time. Now, I'm not saying, hey, coach, can't play the soccer game tonight, wrong timing, wrong thing. Don't want to tear, Travis said I'd tear my ACL, but it's something to think about. PCL, once again, I will tell you that once again in 16 years, we've fixed 3 of them, 4 of them maybe. And even then, they were debating them. 95, so it's just the direct mirror opposite of the ACL. ACL doesn't let your tibia go forward, PCL doesn't let your tibia go backwards. More vertical alignment, less common with rotational stability. That's why whenever you fix your ACL, you get what kind of a brace whenever you go back to sports? A derotational brace, because your ACL is all about translation and rotation. PCL doesn't have that much to do with rotation. Classic case, front passenger seat of an MVA, and they'll hit their tibia on the dashboard, so their femur goes forward like that, and then you also get really bad patellar arthritis after that. They call it a dashboard injury. But that's usually whenever your bottom half of your leg is going forward, your femur's going forward and the bottom half of your leg goes backwards. Super, super rare. Once again, presentation, it's exactly the same as the ACL, only it went backwards instead of frontwards. Same injuries that can go along with it, with meniscal injuries and things such as that. It's a posterior drawer versus an anterior drawer, so instead of, once again, you point them forward, you push them back. This other one, the SAG test, is actually pretty impressive too, because you can usually see it, and they really don't have to do anything to do that. So if I have a patient here, their femur's coming up like this, their knees here, and I've got their feet, you just rest their heels on your forearm, and you take a look like that. And if their PCL is torn, it'll sag backwards. Their calf and their tibia and all of that will sag down, so they call it a positive sag sign. Now, it doesn't mean just if it doesn't sag that it does that. Like, have you guys studied the Achilles tendon tears yet? So you know what a Thompson's test is? Does anybody learn a Thompson's test? Okay, we'll get to that. I'll teach you that real fast. But once again, it'll just sag backwards. Evaluation, once again, MRI, that's the beauty of orthopedics is we MRI a lot of things. Our saying is you only get an MRI to confirm what you think you already know. So I don't get an MRI because I'm clueless about it. Now sometimes if it's some kind of a weird looking tumor or a bony infarct or something like that, but a lot of times you're just doing this to confirm it so that the insurance company will let you do the surgery on them if they need it. So once again, treatment is the exact same except for the bracing would be different. Far fewer have surgical intervention or indication. It's next to never, guys. We don't see that many of them. Once again, it's usually big traumatic injuries. Bracing and immobilizer for 4 to 6 weeks, also with formal physical therapy if they're, once again, older, non-athletic, and or not unstable. Sometimes people just won't be unstable. They'll just be there because their mom made them come. Like I said, most people, this guy that we worked with was snow skiing and didn't have an ACL for 13 years. LCL, least common of the 4 major ligament injuries. Difficult to accomplish because it's usually a varus load. Well, you don't usually hear people getting hit from the inside of their knee outwards. Usually that's more of your martial arts people. So like if they're in their stance or whatever and somebody kicks them on the inside of their knee so it's trying to go out like that. Football player, once again, sometimes they'll have, whenever you see them wrapping them up and they're still trying to run like this and somebody hits them from the inside out. But it's just, that's the beauty of the knee. The ACL is the direct opposite of the PCL. MCL and LCL the same way. One goes in, one goes out. Once again, presentation very similar. Knee fusion, they really like this 4 hours thing, but it usually swells up quicker than that. Lateral knee pain, and what you have to worry about with the lateral knee pain is remember that's also where their iliotibial band runs, because remember that your iliotibial band runs right across that fibular head where your LCL attaches, and what else attaches to your fibular head? Your hamstring, right? Biceps femoris comes down and attaches there, so you kind of have to really check that stuff out, and that's where it's important to go ahead and do resisted. So, and I don't think it said it on the previous slides, but also test their strength. Have them do a knee extension, have them do a knee curl, have them do a straight leg raise, have them walk around their tippy toes, stuff like that. Laxity with varus stress, the same rule applies. As you see, he has whoever that is hung off the side of the table. He does it straight, and you can do it just like this, and then you bend it down to a 30-degree angle and do the same exact thing. Ligament palpable with figure 4 position. So what they're doing is they'll put them over like that, and that puts stress on it. So it's a figure 4 position. I don't really use that one that much. It's a good test, but once again, it's so uncommon. And number 2, if you put them in varus stress and their knee goes to the outside, you kind of already have your guy. Workup, once again, I know this sounds like I'm repeating myself because I kind of am, but it's an MRI. Once again, now with the LCL, you would do the same thing as the MCL. You would put them in a flexion extension brace locked at 30 degrees, put them on crutches, toe touch, weight bearing, and have them go get an MRI. Surgeries indicated. These are actually very difficult surgeries to do. The one that we have done the most is because you have to remember that what nerve runs over your fibular head that you have to be careful of? Perineal nerve, right? So that's why you always, with these type of injuries, you always check their sensation, their first dorsal web space of their foot, between their first and second toes. And in the surgery, that perineal nerve is God. Everybody knows where it is. They will mark it. They will put neon signs flashing towards it. Everybody needs to know where that is. And so what we actually do is they'll anchor it up in the new LCL up in the femur, and then they'll drill a hole front to back through your fibular head and loop it around on itself and tie it. And those are, once again, I've never seen just a single LCL injury. The last one that we fixed was a girl who was in a Volkswagen and got hit head on by a semi-truck. So we fixed her MCL, her LCL, her ACL, and I think she had both of her meniscus were torn as well. So once again, these aren't your Friday night heroes coming in very often. You still need to check it, but it's not as common. All right, meniscus injuries. Meniscus injuries are the bread and butter of our knee exams. We see more of these than any single injury to the knee, more than anything else. So the meniscus, once again, semilunar cartilages, and that's where people get confused because they'll try to Google it and they'll find out about their articular cartilage, which goes away when you have arthritis. But then they'll go, oh, well, I saw some other cartilages in my knee. They kind of look like half moons and they face each other, and those are your meniscus. So you kind of have to differentiate it like that. Articulate with the tibia and are concave in shape. I always tell people that they look like little peach wedges when you get them out of the can. The insides that face, or this part of your hand actually works well. I'm surprised I don't have pin markings on it because that's how I diagram it. But if I do like this, these are what your meniscus look like. The inside's very thin, the outside's very thick. So in one of the analogies I'll give folks when they can't kind of wrap their brain around what a meniscectomy is, I always tell people it's kind of like going to an OU or OSU football game. And if we just take out the first couple of rows of seats, you still have the big banks to go up. So it's not like you're going to get automatically all of this arthritis and things like that. Injury usually occurs with a combination of loading and shearing. So meniscal injuries are a planted foot and then they twist their body like that. I've seen people do it falling when they tie their shoes. I've seen people slipping off of curves, but usually it is the tennis player, the indoor soccer player, the racquetball player, stuff like that. It is people who do a lot of starting and pivoting going back the other direction. And what they'll do is sometimes they'll even say, because if you have a bucket handle meniscal tear, it can actually flip over on itself and it will lock up their knee. They'll just come in and they'll go, hey, this is this. I can't do anything more than this. So you'll get, but usually popping, locking, clicking, catching, and I have trouble turning certain directions. So you can imagine if I have a medial meniscal tear in my right knee, if I'm stepping forward and I turn left, well, that puts that McMurray's test on it, right? Or if it's my left knee and I'm turning right, it can do the same thing. Especially true in the young, healthy patient, once again, your athletes. The meniscal tears in the aging population are usually due to falls. Generally something simple as riding from a seating position. Like I said, we had one lady that did it. She kind of lost her balance tying her shoe while she was standing up, which is terribly hard to do anyway, so I always try to sit down with that. They may be chronic in nature because remember, you can get a meniscal tear by having bad arthritis, right? Because if you think about it, if you have a bone up here and a bone down here, and those are no longer smooth, and you have this nice, pretty smooth thing right in the middle, and when you feel them in real life, they kind of feel, well, you guys had cadaveric anatomy, right? So they kind of feel like mushrooms on a pizza. They're kind of squishy, but they're firm, and they can tear really easy when that arthritis. So when you get an MRI, you will get a, they'll say usually something more of a degenerative type tear, or a degeneration without a frank tear. So zones of the meniscus, and you guys probably already know this already, but the outer 1/3 is where there's a blood supply. So that's why whenever you hear these stories of kids who will go, yeah, I had a meniscal tear and mine healed just fine. Well, that means that it was a certain type of tear in the outer third of the meniscus, because otherwise they just don't heal. The red-white zone, which is in the middle third of the meniscus, it's diminished, but it's not non-existent. And in the white zone, the inner 1/3 is where a ton of those happen. So usually we'll get the tears of the thinner part, obviously. And since there's no blood supply to bring nutrients to them, they don't heal. Location of the tear aids in dictating of the treatment. Maybe commented on the radiologist, because usually, did you guys learn the different types of tears? So you know they have a radial tear which goes out. They call one a bird beak tear because it kind of goes up and in and it kind of looks like a bird's beak. Once again, vast majority of symptomatic tears occur over the inner 2/3 where they probably won't heal. So your patient will say, hey, I have this meniscal tear on my MRI. Is this going to heal? Well, not really. It has a chance to. And remember that the hoop, there's a thing called a hoop stress on your meniscus. So your meniscus look, if you were just to put both of them together, look like a hoop. So the fibers run anterior to posterior over and over. So you can imagine if you have a tear that cuts those fibers in half and you try to sew that back together, it would pull through, right? Because the fibers run this way. So it's like we call it sewing hair together because it's just going to pull right out. The only time you can fix these things is in a very, very small percentage of the population. It's in the outer third, and it's whenever the tear goes along with the hoop fibers, because now you can, so if this is my, let's say this is my medial meniscus on my left knee, and medial. So, and if the tear is right here, now we can go and suture this way because we can close that gap because they won't pull through, but you can imagine it would pull through like that. So everybody get that? Once again, super rare. Out of every, we probably do somewhere between 500 and 700 of these a year, and we probably fix like 3 or 4. It's very, very rare. Now, of course, if you work in a all sports medicine clinic, you're going to have younger population of active people. You'll probably get a little bit more, but still, it's pretty rare. The only difference on the rehab on those is that they can't, the meniscal tears, the meniscectomies, excuse me, that you can walk on those the next day. If it's repaired, you cannot walk on it for the first 4 to 6 weeks. And you can't play sports for 4 to 6 months versus a regular meniscal tear with a meniscectomy, you can probably go back in about 4 to 6 weeks, as long as they're healthy. So once again, most common symptoms, popping, locking, clicking, catching. You will get that ingrained in your brain because they'll come in and say, yeah, every time I turn right, my knee kind of feels like it wants to pop. And then after it pops, it'll feel better because what happens is if you can imagine me cutting this part of my hand right there so you have 2 flaps, what happens is those flaps will turn up on each other. Now it stuffs the joint, and that's uncomfortable for people. And they'll go, yeah, man, it was the craziest thing. My knee was killing me. I felt a pop, and then all of my pain went away. We've even had people cancel surgery because they feel so much better because their knee went back to normal. Their meniscus flaps went back down, and then they'll call back like 3 days later and went, hey, I turned to the right, and it's back again. So can you put me back on the book real fast? So once again, popping, locking, clicking, catching, super huge on meniscal tears. One-sided knee pain, and that's the other thing, is usually when people complain about osteoarthritis in their knee, they'll say, yeah, this hurts. But whenever people have meniscal tears, they say it hurts right here, or it hurts right here in the back. It is usually a pinpoint location, kind of like the fractures we talked about last time. And knee effusion, as Dr. McNeil said, since there's relatively low blood supply, they don't blow up like that. So if you were to aspirate a knee, and they say, yeah, my knee's killing me, it's big and fat and swollen, but then there's no blood in it, you're, once again, meniscal tear. Mrs. Jones, you guys can read these. But basically, twisting injury on a flat, pivoted foot. And that's why soccer players and outdoor football players and outdoor soccer players and all that, so it's anything that has cleats, because in indoor soccer is worse for you, actually, because you know on the grass will give with your cleats, baseball players, stuff like that. The indoor soccer players, most people wear Sambas, or I don't know if anybody's ever played indoor soccer, but those things don't give at all, and that turf doesn't give at all. So usually it's whenever they're on some kind of a turf, they're always going to be tearing up something, although it's crazy fun to play. Impingement of the meniscus tissue, so once again, check terminal, flexion, and extension. Usually they won't want to straighten out their leg all the way, but if you put them in flexion, they will usually come unwound. Provocative test, Apley's and McMurray's. So McMurray's, as you guys will know, you position your hand underneath the fold of their knee, put your hand underneath their shoe, and then so what you would do for a medial McMurray's is you put them in a valgus stress, turn their foot to the outside, so externally rotated, and just go down. And some people will just turn their leg. Do you mind again? Do you care? Hop up here real fast. Sometimes it's easier to see. Yeah, whatever you want to do. You want to lay down right there? So if he, just a little bit more. Okay, so if this is my guy, and I'll put him like this. So some people will just do this. It's negative. I didn't get anything at all. So what you do is you get him more like this, and this is where, once again, get him down here by the foot. So I would have him relax, and if they're tight, I'll even do this. I'll say, hey, let all this go, let this go jiggly wiggly, which once again, girls don't like saying that's jiggly, but it is sometimes. So what you'll do is you'll put them in a valgus stress, and you'll come all the way down. Well, sometimes this isn't enough, and I've even gotten people all the way down to straight, and all of a sudden you'll feel a pop, and they'll go, oh yeah, right there on the middle. So you got to take them all the way down, because if not, you may miss it. Now, I think the true book definition, well, while you're here, I'm just going to do the exam on them real fast. And the true book definition usually says that you should be able to feel the meniscus move underneath your finger. I honest to God, I don't know if I've ever felt it. But it's just, once again, common things happen commonly. So since I don't want to inconvenience him by having him stand up and sit down, I'm just going to do my knee exam and show you guys real fast, and then we can finish up. So my knee exam is this. So first thing I do is I'll have him, you know what Thompson, or not a Thompson, but a Moses test is for a blood clot. So this is a Holman's, right? And then Moses is this. You squeeze them, because I promise you if they have a blood clot, this will actually make them come off the table more than a Holman's will. So what I'll do is I'll check their quads, so make a straight leg raise, or do a straight leg raise for me now. So come up like this, back down. So what do we automatically know that's intact on him? His quad tendon, right? You can't do this if nothing's attached. Patellar tendon, so he's got a straight leg raise, and we know his quad works, right? So what I'll do is I'll put him back like this, so bend your knee back for me. So what you'll do is I palpate the patellar tendon, medial joint line, lateral joint line, MCL, LCL. So you just knocked all of that out right there. If anything hurts, go back and investigate. So if I touch this and he goes, yeah, that's kind of uncomfortable right there, then I'll differentiate between the proximal, middle, and distal thirds, and then you can go for that. So what I'll do is I'll say, okay, and I'm going to sit on the side of your foot real fast. So I'll sit like this. And so this is whenever they have to relax. Because is he relaxed right now? No, his leg's straight up and down, right? So what I'll do is I'll kind of get him like this, and this is when you can kind of do like that. And as soon as you see them do that, so my thumbs are right here, so now relax your leg. So as soon as you feel them drop off, there's your anterior drawer, posterior drawer. It's that. I'm not doing this, right? And what I was talking about with the girls, if you've got a big, huge guy, you can do this and do a jerk. And pushing, it doesn't matter how small your hands are, just push it on there and go like that. So there's your anterior drawer, posterior drawer. And then from here, I'll just go up to a McMurray's. So I'll say, okay, tell me if this hurts you on the inside or the outside. So I'll do a medial McMurray's coming down. Lateral McMurray's, it's the opposite of the medial. Varus stress, foot goes inside and go all the way down straight, because a lot of times they won't feel the pain until they almost get straight, or sometimes when it's all the way straight. From here, you simply put their arm or their leg like this. Let it drop for me. Okay? So once again, here's varus and valgus stress, right? And then just bring them up 30 degrees. There you go, like that. And then right from here, just relax for me. And this is Lockman, so you let their leg fall over, which means they're relaxed. And it's just this. Because if it's torn, that thing's going to come out. And that's the whole knee exam. So done in real time, once again. Okay, so make those straight leg raise, come up and touch my hand. Okay, back down. Now bend your knee up for me. Does this bother you here? Okay, this, or this. Okay, I'm going to sit on the side of your foot, just try to relax as much as possible. And this is where you usually ask them a question. Is it raining outside? You got plans for this weekend? How do you spell your last name? You want them to get their mind off of it. Jerk front, jerk back. And then this is the inside, this is the outside. Anything there? Anything there? Okay, let me borrow your leg for a second. Just try to relax. And once again, give them physical cues. You can just kind of have them relax. 0, 30. Drop it down for me. And lock. And you're done. Right? Now, of course, you can go back in the pivot shift test. So what I was saying about the pivot, I'm going to do it to you. But a pivot shift is actually, so you have them like this, and you have their calf here and their ankle here, and I'm putting a large amount of varus or valgus force on him, and I'm just going to go up, and about right there, if his ACL is torn, it'll go like that. It'll just jump out, and that's a pivot shift. You go ahead and sit up. Thank you again. Okay, so that's where it is. The Apley's, I don't do that one very often because you basically just turn him over on his belly. I should have done it with you over here, it's fine. But you turn him over on his belly. Now his femur is here, his kneecap is right here, and his foot and ankle are right here, and you're shoving it down, right? You're pushing it down into the table and doing the same twist. Once again, if you have a positive McMurray's and a negative Apley's, you're still worried about a meniscal tear, right? Okay. Deep squat, duck walk, it's unnecessary, but you can if you want to see if they'll do it. So here's an athlete right here, so he's pushing downwards and then internally and externally rotating it. So of course, if your foot is going out and it hurts on the inside, it's a what? Tear. Which one, medial or lateral? Foot goes out, it hurts on the inside.
Medial.
And then opposite the other way, right? McMurray's, once again, probably the most well-known technique, combined with a modified Apley's. I'm not saying that this one's kind of the one I was describing where you use the varus and valgus stress along with it. Because once again, if I just have him laid up there and I just spin his ankle, that's not really catching anything. You're trying to pinch it, right? Okay. Meniscal workup, once again, x-rays will not show anything. We have people come in all the time. Well, I went to the emergency room and I got an x-ray and they said I had a meniscal tear. I was like, okay. So we'll just go ahead and go get that MRI. So MRI, once again, 80 to 90% accurate for diagnosis of meniscal tears. Gold standard second only to diagnostic arthroscopy. A diagnostic arthroscopy is where we take you to surgery right away and go look with our own eyeballs. And that's the best way to think about that, but nobody does that unless you come back and your MRI is negative and you're still having all kinds of pain. Meniscal tears on MRI, so these little triangles right there are your meniscus. So you can imagine that something is shaped like a half moon. So the further in you go, it's going to be two pieces, and as you start to come out to the periphery, it's going to become one piece. So you'll usually see it back here in the back. Anterior horn, so they call them horns, so this is the posterior horn, anterior horn. Anterior horn tears are very, very rare. Usually it's in the posterior horn, just due to the mechanics of it all. This is a meniscus in real life, and you see how that one, so you can imagine if this is a hoop, so it starts back here and comes around and then like it goes like this. So there you can see the tear is in alignment with the fibers, right? So that would actually be one. If it was a little bit further to periphery, you could put sutures across here and it would actually hold. But you can imagine if you had a tear that went from here to here and you tried to put sutures this way, it's not going to hold. And that was what I was explaining earlier. Patient well-tolerated or conservative treatment, we do have people that do have meniscal tears that have no mechanical symptoms at all. Or they'll have mechanical symptoms and their meniscal tear will lay back down and they don't anymore. No deficit in passive range of motion, no locking, clicking, catching. So people always come in, they say, okay, the MRI says I have a meniscal tear. I obviously had enough pain to come in and get an MRI. But now you're saying I don't have to fix it. Yeah, if you're not hurting it, it's not getting worse. How do I know if I'm tearing it more? Because that's what's going to happen with a meniscus, is it's going to tear more if you keep putting pressure on it. So that's what we tell them is if you can get along and do things without limping. Limping is always the gold standard of you're making yourself worse. If they can do things without limping, you're probably not tearing your meniscus more. If you're doing stuff and you're experiencing the popping, locking, clicking, catching, you're probably making it worse. Conservative treatment, once again, rice anti-inflammatories. We do give steroid injections for these as well. Activity modification, which means if you tore it playing racquetball, you may want to lay low on racquetball for a while. Bracing is not effective. People come in every single day and ask for bracing on a meniscal tear. A brace will not help you. It will do nothing more than help with the swelling. So if people ask me, I'll say just go get a sleeve. Because if you imagine, let's imagine this scenario. So if this is my femur, this is my tibia, here's my two meniscus. So if I have this, and I know that my meniscus is strained by doing this, do any of you know a brace that won't let you do this? Right? So you'd almost want a brace that pulled your two bones apart, right? That distracted them so you couldn't grind on it. Well, they don't make those, right? So we usually do not do bracing for meniscal tears just because, number one, I don't know of one, and number two, the surgical treatment for these, this is, like I said, this is kind of our bread and butter. We'll have you back up and running in no time. Surgical debridement or repair, once again, repair is ridiculously rare. Symptoms that affect your activities of daily living, that's ADLs, I'm sure you guys knew that already. Bucket handle tear that blocks range of motion. Obviously, if you can't bend or straighten your knee, you can do that. Now, an interesting thing is, do you guys remember the snow mask technique that I told you about, reducing the shoulder? You can actually do the same thing in the knee. You can fill their knee with lidocaine, or even sometimes sterile saline, well, I don't do sterile saline, but lidocaine, and start to gradually straighten and bend their knee, and you can actually unlock that whenever you distend their knee enough. It's very, very rare to do that, but we've had to do that before, because sometimes people can't even walk. Their knee will get, bless you, their knee will get stuck at a 90-degree angle, where you can't walk like that, and you can't sleep like that, and it's very hard to do a lot of things. The treatment for these includes partial meniscectomy, which is by far the most common. The meniscal repair, which is ridiculously uncommon in this. Does anybody know what this is? This one's a mince answer. Does anybody know what this is? A hole? But what do you do with the hole? Do you know what the actual word means from Greek? It means auger, so it means a hole. So does anybody else know where this word actually, they started using it way, way, way back before we started doing it in these? Right, so let the evil humors out of your head when you're crazy. There you go. So there's your mints. So this is archaic. Nobody does this anymore. This hasn't been done since probably the 90s, I would guess. But once again, this was kind of passed down to me. So what the theory was is that you could actually make a little tunnel from the blood part of it, the outer third, to the inner third, to kind of like irrigate it almost. And it didn't work at all. So they don't do it anymore. So that's what that one is. That one's just kind of a fun piece of history for you there. Okay.